So, hey, good morning, guys. Let's go ahead and get started. We're running a few minutes late. Some connecting issues. So, my name is Nadejda Tsankova, and I'm one of the neuropathologists here. And I'm going to be talking about central nervous system tumors today. So, I'm going to give you an overview of the very, very different types of brain tumors that we see. And the locations where you tend to find these. And then we'll start with talking more about histology, and we'll start very simple, just sort of talking about what's normal and how we distinguish normal from neoplastic. And we'll spend a lot of time on talking about grading of gliomas, and then in general about the new molecularly integrated classifications of gliomas. And then in the second half of the talk, we'll focus on some other CNS tumors, including those that you see in familial syndromes. And we may not get to this, but if we have time, we'll talk more about just specific things about GBM, which is the most common malignant brain tumor. I thought so.
Okay.
Thank you.
All right.
Okay, yeah.
Okay.
Thank you. Okay, so, the good thing is that gliomas are actually relatively a rare tumor compared to, lung cancer, breast cancers, or colon cancers. But still, we have over 700,000 people living with a brain tumor in the USA today. And unfortunately, a sizable proportion of these, like 20% of them, are malignant. And people with these malignant tumors have a very dismal prognosis. So they're very important to understand and correctly diagnose. The majority of brain tumors, about 60% of them, what's happening? Yeah, it's going.
It's not, but you can go ahead. I'm just trying to figure something out.
Okay. So the majority of brain tumors arise from the neuroepithelium, which is basically the brain or the spinal cord parenchyma itself. Then about a third arise from the meningeal surface of them, and a small proportion from spinal nerves and the cranium. And as far as prevalence, gliomas are the most common malignant brain tumors. Meningiomas are also very common. A third of primary brain tumors are meningiomas. GBM is the most common malignant brain tumor in adults. And then in children, actually, brain tumors are the second most common cancer after leukemia and the leading cause of cancer-related deaths. And when we think of pediatric brain tumors, we think of pilocytic astrocytomas on the spectrum of more benign tumors, but also medulloblastomas on the spectrum of most malignant tumors. And ependymomas are also seen in kids. So we'll talk about these different tumors. As far as mortality, GBM is by far, the worst of the tumors with a very dismal prognosis. And what causes brain tumors? We really don't have these environmentally associated factors like we have with lung cancer and things. A whole brain radiation has been associated with the cause of some meningiomas, but for the most part, most brain tumors arise sort of sporadically or through familial syndromes. All right, so here I just kind of subdivided the different types of tumors you expect to see by location. In both brain and the spinal cord, you should think about tumors arising from the dura. These are our meningiomas, hemangioblastoma, and some more uncommon melanocytic and histiocytic tumors. And then the majority of them really arise from the parenchyma, as I said. These are the ones we'll spend the most of our time talking to. So we have the glioblastoma, we have astrocytomas, oligodendrogliomas, medulloblastomas, by definition arises from the cerebellum. That's the name. And we can also see primary CNS lymphoma. These are all tumors with pretty bad prognosis. And then we have some other tumors that are more low grade and typically associated with epilepsy, also arising from the parenchyma. Certain tumors arise from the ependymal lining in the ventricles that we'll talk about, like ependymomas, neurocytomas. and some few arise from the skull base, and then we have nerve-associated tumors here that we'll touch on at the very end. All right, so before we jump into brain tumors, I think it's worth just appreciating what a normal brain looks like. I know that you've already had that, so I'm not gonna go into a lot of detail, but it's still, every time I begin rotation with a resident or a fellow, we first go over what's normal. And so here's a piece of normal brain, and this looks very different from, other organs that you've looked at, because the structure is very kind of pleomorphic, but it's hard to find like discrete, glands, for example, and things like that. But we do have different types of cells. So we have our neurons, and these are our very large cells with a prominent nucleolus. Most tumors don't arise from neurons. Most tumors actually arise from the glial component. So we have different types of glia. The small cells you see here, the sort of like tiny round cells. This is a piece of like white matter, and what's in the white matter? We have oligodendrocytes. They're really concentrated in the white matter, but you see them throughout. And then astrocytes are really hard to find in the normal section of brain. We see them more under reactive conditions. So this is an example of a reactive astrocyte. You see this sort of centrally located nucleus and this eosinophilic cytoplasm. We call these epimastocytes. It's another name for a cell that has this eosinophilic cytoplasm and nucleus to the side. You can see them in both reactive and in neoplastic conditions. So this is a brain with a lot of reactive astrocytes. This is not a tumor. And the reason it's not a tumor is that all the cells are sort of respecting each other's boundaries. They're not crowded together. And of course, you don't see a lot of nuclear atypia as well. So this is my analogy to a normal brain. This is basically the subway, on a Saturday morning, and everybody's like sitting down, respecting each other's boundaries. This is our normal brain. And then contrast normal to a high-grade glioma. All of a sudden, we have, crowding of cells, a lot of disrespect, like a lot of atypia, mitotic figures. So this is my analogy. This is a subway on a Friday afternoon. So no personal space. Tumor cells are abutting one another. Mitotic figures, just like an angriness. So, of course, we have to talk about how we actually make sense out of all these angriness and atypia. And so we've come up with a grading system for gliomas, and we'll go through that grading system now. And we sometimes use this acronym AMEN, which may or may not be useful to you, but let me sort of generally go over how we grade gliomas, and then touch on, there's always exceptions to the rule, but I wanted to kind of give you like some sort of a general sense first. So the first thing we look at is this like an infiltrative lesion, or is it a more well-circumscribed lesion? So we have a few low-grade gliomas that are really the lowest grade, grade 1, and we only reserve grade 1 for those types of tumors that are, we kind of call them benign, in the sense that they're really not very infiltrative, so you could potentially completely resect them and the patient will survive, long term. So most of these are typically associated with, people with long-standing seizures, things like that. They're a little more malformative, and they rarely tend to progress. Now, infiltration really puts us in a different category of gliomas, these more diffusely infiltrating gliomas. Diffuse astrocytomas is one category, oligodendrogliomas is another category, ependymoma, and this category of pleomorphic xanthroastrocytoma, it's actually a whole grade 2, but it's a little bit an oddball. But for the most part, these are tumors that begin as a grade 2 and eventually will become anaplastic. And so while they're a grade 2 tumor, they have their low cellularity. Importantly, there's no atypia and pretty much no mitotic figures that we see. And once we start to see atypian mitosis, so the AM of the acronym, they become grade 3 tumors. So anaplastic tumors have nuclear atypia, and you should see several mitotic figures, and we can talk about which one, how many mitotic figures. It becomes kind of complicated and sort of there's a little bit of inter-observer variability in what you call anaplastic, but the important thing is that you should see mitotic figures in atypia. And once you see, in addition to that, a vascular proliferation and necrosis, it becomes a grade 4 tumor or a glioblastoma. So this is an example of a grade 2 oligodendroglioma, and you can see the cells are sort of small, no mitotic figures, and this is an example of the type of tumor that has now progressed into a grade 3 tumor. So you can see a lot more nuclear atypia, you can see mitotic figures, things like that. While they're a grade 2 tumor, these tumors tend to be like non-enhancing on brain MRI, but once they become a grade 3 and especially grade 4, they become contrast enhancing. And a lot of that is because of the proliferative vessels that are allowing the contrast to go through. So an example of a grade 4 tumor, of course you probably know, this is a glioblastoma. It's got the features of pseudopalisading necrosis and glomeruloid vascular proliferation. You only need one of the two to actually call it a glioblastoma. So a few things, when we grade an astrocytoma, we have a very low threshold to call it anaplastic. Really all we need is just like 3 or more mitotic figures in the entire specimen. And that's something that actually you don't read in the books. It's just something that pathologists you kind of read it in the books, but it's really more sort of a consensus among neuropathologists that more than 3 mitotic figures are enough to call something an anaplastic astrocytoma. And as I said, these eventually will progress to glioblastomas once they have endothelial proliferation or necrosis. Whereas an anaplastic oligodendroglioma or an anaplastic ependymoma, we actually have a higher threshold to make those anaplastic. We need more mitotic figures. These are actually allowed to have vascular proliferation and necrosis. That doesn't make them a GBM. So that for oligos and ependymomas, the worst they can get is a grade 3 tumor, whereas astrocytomas can progress into GBMs. So that's a little bit the exception to the rule of grading. Okay, so I'm going to start by showing you some pictures of grade 1 tumors and then go into the grade 2, 3, and 4. So as you remember, I told you these grade 1 tumors are low grade, they can be completely excised, they're not very infiltrative, and so they have actually pretty good prognosis. And it's very important to diagnose these, but sometimes it can be tricky. So pilocytic astrocytomas, pilo means hair, and these cells tend to have these like coarse hair-like processes. They kind of can look a little spindly. What's like sort of pathognomonic for them is the presence of these Rosenthal fibers. There are these very highly eosinophilic accumulations of intermediate filament that you see in pilocytic astrocytomas. They're mostly seen in the cerebellum and in kids, but they can occasionally be seen in adults too. And some other areas where you can see pilocytic astrocytomas is like the hypothalamus of the midbrain. The spinal cord is another common place. And if you see them in the optic tract, they're typically part of the syndrome of neurofibromatosis 1. So that's an important one. If you read about NF1 patient with optic tract glioma, what that is actually a pilocytic astrocytoma. This is important. This is a new molecular alteration that was just discovered in pilocytic astrocytomas a few years ago, and it's really present in the vast majority of them. I think up to like 90% of the cerebellar ones have it. The BRAF mutation is actually not so common, but we'll talk about some other tumors that have the BRAF mutation. But both the BRAF mutation or the fusion are sort of like feeding into the same BRAF MAP kinase pathway activation. The best stain for these tumors is GFAP. Okay, another really weird grade 1 tumor that's kind of thought to be a tumor but also like a malformative lesion is this DNET, or this embryoplastic neuroepithelial tumor. And that can sometimes be confused with oligodendrogliomas and other things, so it's important to differentiate it for other types of gliomas that are higher grade. So you see these sort of oligo-like cells everywhere, but what's really interesting about this tumor is the presence of these mucinous microcystic structures and neurons sort of floating within this mucinous microcystic structures. So that is how we diagnose these tumors. And of course, we look for some mutations in them. They can have the BRAF mutation, but not really any of the other type of mutations that are seen in oligos. But that's the type of tumor that you might confuse with an oligo. All right, this one is a really weird tumor that actually has both neuronal and glial components. It's also a grade 1 tumor associated with epilepsy, ganglioglioma. This is an example of the type of dysplastic neurons you see. Ganglion-like looking, those might stain with NF or synaptophysin. Sometimes they also, weirdly enough, stain with CD34. And then, you kind of see some more glial cells here in the background that look smaller and more hyperchromatic. So that's sort of this vague glial component that these tumors also have that stains with GFAP. They can also have the BRAF mutation, not the fusion. And then finally, pleomorphic xanthoastrocytomas PXAs are another one of these weird epilepsy-associated tumors, but they are actually a grade 2 tumor, so that's the only thing to remember, one of the things to remember. The other thing to remember is that they have these eosinophilic granular bodies, or EGBs, and very pleomorphic, multinucleated cells that often look very foamy and xanthomatous. And this is an example of one. If you look at them on gross sectioning, they are very yellow looking because of all the fatty xanthomatous change that they have. And molecularly, a lot of them have the BRAF mutation. So with gangliogliomas, a few of them have, but these really, like 2/3 of them have that mutation. And they're typically seen in the cortex. Okay, so now we're going to start talking about, the most sort of common type of gliomas, which are the more infiltrative type tumors. We'll start with oligodendrogliomas. Histologically, the perinuclear halos are, the most important thing for these cells to look for. You really should see these halos. If you don't, you should really question, is this really an oligo or not? Just because the cells might look round, that doesn't necessarily mean it's an oligo. And in addition, they have this chicken wire vasculature. What's really, really important about these tumors is that all of them have 1p19q co-deletion, which you can diagnose by FISH. If a tumor does not have that, it's really not an oligo. In addition, they also have IDH mutations, all of them. Okay, so these tumors, as I said, they can progress to an anaplastic oligo. That's as far as they're going to go. In anaplastic oligos, we really want to see at least 6 mitotic figures and 10 high-power fields. Typically they have a MIB between 10 and 20%. You also want to see some nuclear atypia, not just MIB1. And you can often see vascular proliferation and necrosis in an anaplastic oligo, but you don't really have to see it. Even just seeing the mitotic activity is enough to call it anaplastic. This, you guys can see this is what actually a chicken wire vasculature looks. And you can sort of, we have a lot of imagination as neuropathology, so you can definitely see that in this case, there's a good chicken wire vasculature. So, all right, so then we jump to astrocytomas. And sometimes they're very easy to distinguish from oligos, specifically when they have this more gemistocytic look. So remember I showed you a reactive gemistocyte. This is a neoplastic population of gemistocytes. You can see how they're on top of each other. much higher proliferation. There's also atypia. And when they're a grade 2 tumor, their MIB1 is actually pretty low, maybe just a couple percent. But if you have more than 5%, you actually go into the territory of anaplastic astrocytoma. Here you can see an example where you are starting to see cells with more nuclear atypia and mitotic figures. Now, sometimes astrocytomas can have this look, kind of more small, round nuclei. So people used to confuse these sometimes with oligodendrogliomas, but they still have a lot of eosinophilic cytoplasm. These are more fibrillary-looking astrocytomas. And then when we have a hard time distinguishing them by histology, luckily we can use molecular help. So, like oligos, astrocytomas also have the IDH mutation, pretty much all of them, but they don't have 1p19q. Instead, they have mutations in p53 and in ATRX. And that's very important. So, oligos, 1p19q, IDH mutations, astros, IDH mutations in either ATRX, p53, but not 1p19q. Okay, moving on. Astrocytomas can progress to GBMs, but the majority of GBMs actually arise de novo. Patients present, with sudden onset of seizures, and they're found to have these very malignant-looking tumors. And they're actually pretty easy to diagnose. As I said, you need either or vascular proliferation. This is a nice glomeruloid vessel that everybody will agree is glomeruloid. It has multiple layers, and it looks like a glomerulus. You'll see it on the kidney. And this is, a nice example of pseudopalisading necrosis. We can have some histological variants of primary GBMs. This is an example of a giant cell GBM where the majority of cells have this giant cell appearance. This is this very rare example of an epithelioid GBM where the cells kind of look more rhabdoid. And these are important because they're associated with BRAF mutations, which is pretty much not seen in any of the other GBM subtypes. And then some GBMs can actually transform into like a mesenchymal component, which if we see true mesenchymal transformation, we give it a diagnosis of gliosarcoma. But all of them are basically subtypes of GBM, and all of them are grade 4 tumors with overall bad prognosis. So the only thing that has a better prognosis is whether it's a primary versus secondary GBM. And as I said, the majority are primary, and these are sort of some of the defining mutations that primary GBMs have. They typically have EGFR mutations, EGFR amplification, which sits on chromosome 7. So, chromosome 7 is kind of gained in these. And some other, PTEN, some other sort of tyrosine kinase pathways. PDGFR alpha can also be amplified. But what they don't have is IDH. IDH is on this side. These are our secondary GBMs, the one that arise from lower grade astrocytomas. GBMs with an IDH mutation actually have much better prognosis overall. I mean, not entirely better, they still succumb to the disease, but it has become an important marker. So these IDH mutations were discovered in about 10 years ago now, and what the papers showed is that IDH mutant GBM, as I said, have, a notably higher overall survival. And so it became, the neuropathologists met and said, we really should integrate this into the diagnosis of GBM because it really stratifies it better than actually histology could. So in last year, actually, there was a new classification update on classifying GBMs, where no longer is histology the only thing important in classification. So far I've talked to you about histology, and now we're going to overlay the molecular. So it's very important now to check for IDH status in an astrocytoma or an oligodendroglioma. Most of those should fall into the IDH mutant subtype. And then you use 1p19q co-deletion status to confirm, is this your oligo or is this a diffuse astrocytoma, both of which are IDH mutant. And the same goes for GBMs. We subclassify these as IDH mutant, IDH wild type. If we cannot do the test, or something, or we haven't done the test yet, or it's inconclusive, then we'll say NOS. And it's important. It doesn't, it's okay to say NOS because you really should not sign it out without really having that genomic information there. So, okay, so this is kind of how we were up until 2016. This entity, I don't even want you to think about it because it's no longer there. It sort of died with the molecular subclassification. But this is how now we diagnose brain tumors. So every diagnosis should have an integration, whether it's IDH wild type or IDH mutant, and whether it has 1p19q co-deletion. In addition, so luckily we have a very easy way of diagnosing IDH mutation. The most common IDH mutation is IDH1R132H, seen in maybe 90% of IDH mutant gliomas. So, a German company developed this very, very useful antibody that actually picks the mutant form of IDH. And it's been working very well for us. In a few cases, like 5 to 10% of cases, the tumor is not IDH mutant. And if this is a glioma in a patient that's young, actually the cutoff is 55 years old, then we reflexively do NGS sequencing to actually make sure that there isn't an alternative IDH mutation that might be making this tumor mutant. And we've seen, over the past few years, we've seen at least 10 or 20 cases that have been like that. This is our little panel that we use that you guys know about. It's not the best for gliomas, but it does pick up a few important genes. EGFR is one of them, but most importantly, it sequences the hotspots of IDH1 and IDH2. All right, so there's a few other gliomas that I won't spend much time on, but these are also gliomas that are now, their diagnosis is considered, the integrated molecular alteration is considered part of the diagnosis. Ependymomas, real effusion positive, and the medulloblastomas and these diffuse midline gliomas, which not sure if they're going to be around forever, so I'm not going to spend too much time on these. And I already talked about these other tumors that have BRAF alterations. And we have actually several other immunostains which we use to diagnose these alterations. BRAF you guys know about. This is a histone mutation. And EGFR we can actually test by CISH, similarly to the way HER2 is being tested in breast cancer, and we can detect EGFR amplification, which is increased copy number of this black signal. I think more importantly is to talk about ATRX mutations. So unlike IDH, where the presence of a mutation gives you immunostaining, with ATRX mutations, the presence of a mutation leads to loss of nuclear staining. So basically, when ATRX is mutated, the protein is not made anymore in the nucleus, so you get loss of staining. This is a nice positive internal control of a vessel, and this is a tumor where the majority of cells are not staining for ATRX. So this is a mutant ATRX mutant astrocytoma. This is more what a wild type tumor looks like. So ATRX is important for our astrocytomas, as I said. I may skip through this part. And it's basically, I wanted to just tell you what IDH actually is, since it's becoming such an important marker in gliomas. It's actually part of the Krebs cycle. It has a normal function in our Krebs cycle that we learned in medical school. But when it becomes a mutated, it shifts the Krebs cycle into another metabolic pathway. And that metabolic pathway and accumulation of this metabolite pretty much like screws up the epigenome. And what happens is you get sort of globally an increased level of hypermethylation. So this is a normal DNA that's nicely open and hypomethylated. Well, mutant IDH1 pushes things, pretty much inhibits these enzymes that normally hypomethylate and makes things hypermethylated. So why is that important? A lot of genes, can be shut off when things are hypermethylated. One of the genes that gets shut off is MGMT. And MGMT is important because it's a DNA repair enzyme. And DNA repair is important in the normal cell, but actually in the cancer cell, you don't want it to repair DNA. So we actually use chemotherapy, like temozolomide is one of the most useful chemotherapies in gliomas. And it turns out that if MGMT methylation is detected, it helps temozolomide to work on killing tumor cells by inhibiting MGMT. But if it's not methylated, it doesn't work so well, and cells end up surviving. So IDH mutant gliomas tend to be hypermethylated, and if you test for MGMT, it tends to be methylated in IDH mutant gliomas, with some exceptions. I'm not going to talk much more about that, but that's, you will rotate through molecular and you'll hear a lot about MGMT, so I wanted you to have some perspective. So now we're going to talk about other types of brain tumors, the ones that arise from the ventricles and the dura and the skull base. So meningiomas are also very, very common, so should spend some time on meningiomas. They're mostly seen sporadically, but they can be seen in the context of radiation, post-radiation, or neurofibromatosis 2 patients. What's characteristic is these whorls that you see in the meningiomas, or these lobules, this sort of pseudosyncytial pattern, some mama bodies, and these are our helpful IHC stains for meningiomas. They can have different histological looks, many, many different ones. Here I just showed you one that's a secretory meningioma. This is a grade 1. I'll talk about grading, and for the most part we just count mitotic figures for grading, but there are a couple different histologies that can also cause a higher grade of a meningioma that you should remember. Clear cell meningiomas and choroid meningiomas. If you see that, if this is like a predominant histological feature in these, you can call these a grade 2. And if it's a papillary or rhabdoid, you can call it a grade 3. Okay. Yes, so the way we grade meningiomas is we count mitotic figures and 10 consecutive high-power fields. If you have less than 4, it's a grade 1. If you have between 4 and 19, it becomes a grade 2 or an atypical meningioma. Another way you can get to grade 2 without mitotic figures or with is brain invasion. That makes it a grade 2. Or if it has 3 out of 5 of these other more vague classifiers, such as sheet-like growth pattern, prominent nucleoli, necrosis, small cell change, or increased cellularity. And as I said, this histology is also a grade 2 histology. And then anaplastic, and so this is an example of an atypical meningioma. And then anaplastic meningiomas, those are rare. Only about 5% of meningiomas reach that point, but they're pretty nasty. They almost start to look like a sarcoma. You might have just a very vague whorl that's still present. Lots of mitotic figures, 20 or more is what you need to diagnosis is one, as well as this histological patterns, papillary or rhabdoid. Hemangioparasitoma / solitary fibrous tumor. You guys, are learning that probably in your lung pathology lectures, but we see those as well in neuropathology. And most of the ones we see have the more hemangioparasitoma, like look with the staghorn vessels. That's automatically a grade 2 histology. And if we count 5 or more mitotic figures and 10 high power fields, it becomes a grade 3 tumor. So that's a little slightly different of, what we see in meningiomas. And then, as you probably have heard, this new fusion that was discovered in these tumors, the NAB2 STAT6 fusion, causes expression of the STAT6 transcription factor. So we really like to use that for immunohistochemistry. But of course, you can use kind of other things like CD99, factor 13A, and these other factors. Progesterone receptors typically only very focal or negative in these, as well as EMA, but it can be focally positive. So we really like to rely on histology and STAT6 to diagnose these tumors. Okay, ependymomas. These are very interesting tumors. They arise from the ventricles, so they kind of recapitulate a little bit the ventricular structure. They can form true rosettes, or most commonly you see these perivascular pseudorosettes. It's a pseudorosette because it's really more of a perivascular arrangement of cells, but you see how like this sort of immediately next to the vessel you have this clearing and cells are kind of jumbled up, almost palisading, or sort of radially arranged around the vessel. That is a true nice perivascular pseudorosette. The cells kind of have this homogeneous chromatin pattern. Grade 2 ependymomas, there's not a lot of atypia. The cells are, sort of nice, homogeneously looking. As I said, Rela fusion is a new fusion that they have found, particularly in supratentorial ependymomas. Those are the ones that, are above the cerebellum, above the tensorium. Not in the posterior fossa, and they have a poor prognosis, these particular Rela fusion ones. But in general, ependymomas have pretty good prognosis, and the most important thing for them is to gross total resection, because they're not super infiltrative. So if you really resect the tumor entirely, that's actually a better prognosis than even whether it's a grade 2 or a grade 3 tumor. They can have this like dot-like EMA staining, but it's usually very focal and not really seen in a lot of the ependymomas. So histology is actually more useful in making the diagnosis. And GFAP staining can sometimes nicely highlight these perivascular pseudorosettes. All right, the other thing on your differential, if you have a tumor arising from the ventricles, is a neurocytoma. They tend to arise from the lateral ventricles, and sometimes they can look a little bit like ependymomas, but you really should not see perivascular rosettes, pseudorosettes. What you should look for is these more vague neurocytic rosettes that are hard to appreciate sometimes. So the other thing is they have this like centrally located little nucleolus. They're almost like tiny little neurons. And they stain with neuronal markers, so that's another difference between ependymomas and neurocytomas. And then this weird tumor that you only see in the end of the spinal cord. So this is the end of the spinal cord. We call the conus medullaris, and this is our filum terminale, the end of the cauda. So in this region is where you see these myxopapillary ependymomas. And they have a very classic look with, this sort of mucinous areas and papillary structures. They're actually a grade 1 tumor, unlike other ependymomas. So they're kind of a special entity. I could see how people might put that on your boards because they're so like unique and pretty rare. But they are really associated only with this region. Okay, so another interesting tumor that we see in neuropathology are chordomas. They arise from remnants of the notochord, the embryonic notochord, which forms along starting from the skull to the end of the spine. So the most commonly places that you can find these is either in the clivus of the skull base, which is midline, or all the way in the sacrum of the spinal cord, in this region. So what's specific about these cells is their phycoliferous look, or their very bubbly cytoplasm, and of course their mucinous background too. You can have a lot of inflammation you see in these tumors. As you guys know, brachiuria is a very good way to stain them, but unfortunately we don't have that stain here. So we rely on histology. Okay, craniopharyngiomas is another sort of a midline tumor that arises from the craniopharyngeal duct remnants or rests of cells, and it comes in two forms, adamantomomatous or papillary, and these two have sort of been found to have specific mutations. Okay, so now we're coming to different familial brain tumor syndromes that I want you guys to be familiar with. So neurofibromatosis 1, those patients tend to have neurofibromas and optic gliomas, which, as I told you, are actually pilocytic astrocytomas. NF2 patients have these bilateral acoustic schwannomas, but in addition, they can also have other gliomas. So, don't be tricked in thinking they only have schwannomas. They can actually have ependymomas, meningiomas, diffuse gliomas even. Patients with tuberous sclerosis, and I'll give you an example of that, have this unique, in addition to tumors in their brain, they have this unique tumor that's called SEGA, or subependymal giant cell astrocytoma. Patients with von Hippel-Lindus disease have hemangioblastomas, in addition to all the other, tumors they have outside of the CNS. And, because they also have renal cell carcinomas, well, they can actually sort of mimic some of the histology of hemangioblastoma. So we'll talk about that. This is a weird syndrome. People with P10 germline mutations have these dysplastic cerebellar gangliocytomas. I've never actually seen one, except in teaching sets. So these are weird things. As far as people that get GBMs or medulloblastomas, bad astrocytomas, obviously people with the Li-Fraumeni syndrome and TP53 mutations, or people with these mismatch mutations, or like people with Gorlin syndrome that have patch 1 or patch 2 mutations, they get medulloblastomas. And finally, rhabdoid tumor predisposition syndrome with SMARCB1 mutations get atypical teratoid rhabdoid tumor, ATRT, which is something we see in the brain of basically very rare. It's basically I&I loss that confirms this, and it's a tumor of infancy. So let's quickly talk about these. Neurofibroma, so this is a tumor that arises from the nerve, and you guys have seen it in other contexts, but basically you have these sort of shredded carrots, these collagen bundles, and it's a mixture of like nerve twigs that stain positive with NF, and some, S100 positive cells, some fibroblasts, and as I said, optic gliomas and NF1 patients. They can also NF1 patients can also get these more malignant nerve-shaped tumors, MPNSTs, and there, you kind of see this sort of fascicular growing sarcomatoid cells. You can have some S100 that can be very focal, but really that sort of fascicular growth is very characteristic of it. And NF2, as I said, this is where, our schwannomas. Most schwannomas that we see are in people without NF2 mutations, just sporadic. But if you start seeding them bilaterally, that's when you start thinking that the patient may have NF2. And you guys know the varicate bodies, these palisades are characteristic of them, and then Antony A, the more hypercellular areas, and Antony B would be the more hypocellular areas, and S100 is a good stain, and then SOX10 is actually, as Amir knows, is a great stain actually to highlight schwannomas, because they're of neural crest origin. So these patients can get other tumors, and here's an example of the ependymomas that we already talked about. Nice perivascular pseudorosettes. All right, this is hemangioblastomas. These are kind of weird, interesting tumors, very vascular tumors. So you see lots of vessels here. You can stain those vessels with CD34. But actually, the neoplastic cells are not the vessels. The neoplastic cells are in the stroma, and there are these cells right here. They have like a very, also kind of a foamy cytoplasm and small little nuclei. Because of their look, they can be confused with, clear cell renal cell carcinoma. So it's important to rule that out with EMA or CD10 or whatever stain you want to use. But what they do stain for is inhibin alpha. So that's probably the most reliable stain. Other stains are not as reliable. So these are important. These tend to occur in the cerebellum, as you can see here in this patient. You can get a hemangioblastoma without having the VHL mutation. That's just the association that we have. Whereas these tumors here, you only get if you have tuberous sclerosis. You never see them sporadically. There are these very weird astrocytic tumors. It stands for subependymal because they're just underneath the ependyma of the lateral ventricles. So you see this lateral ventricles here, and here's our tumor. It's almost like a malformation, but it is an astrocytoma. These are large, bizarre astrocytes. They can be multinucleated, but luckily this tumor doesn't infiltrate. So if you resect it carefully, you can actually, allow the patient to have a long-term survival. Unfortunately, these patients get other things like tumors throughout the brain, so they have lots of seizures, autism. It's a bad syndrome to have. Okay, last few minutes, we're just gonna touch briefly on embryonal tumors. We don't see a lot of them here, but these are important, tumors that are now also a lot of molecular things are emerging in them as well. So medulloblastomas, this is our diagnosis of medulloblastomas in the recent past, but now we actually have to diagnose them either based on histology with a very, important distinctions in the histology, or the best way to diagnose them is if you can do the genetic test is by their genetics. So they, I think Amir gave a very nice presentation recently on the different subtypes of medulloblastomas, but we have ones that are activated by the Wnt pathway and have beta-catenin mutations, or we have those that are activated by the sonic hedgehog pathway and have mutations in the sonic hedgehog. And then you have these other ones that are neither one that people are trying to figure out. So far they call them group 3 and group 4 for lack of a better term. Okay, and then we have something we used to call PNET that is no longer actually a diagnostic entity. PNETs are now called CNS embryonal tumors, NOS, and eventually we're going to start defining them by their molecular profile because they're basically too undifferentiated to call anything else, but they're going to have their specific molecular alterations and some other weird tumors that you may encounter. So very quickly, this is sort of the medulloblastoma subgrouping. What's important is that, for example, the sonic hedgehog pathway is really seen with this desmoplastic, nodular desmoplastic histology, whereas other pathways can be seen with more classical histology or sometimes this like large cell anaplastic histology. So the histology can somewhat correlate with the molecular. It's not 100%. And these are some of the different histologies of medulloblastomas. The classic look is your small, or it's not really small, but small blue cell round tumor, basically large cells with lots of large nuclei, not a lot of cytoplasm that sort of mold together. This is the desmoplastic nodular variant where you have these nodules surrounded by reticulin-rich desmoplastic stroma. And you can also have this extensive nodularity variant and the large cell anaplastic variant where the cells are just super big and have additional anaplasia. And some of the immunostains that are useful for medullos are neuronal markers like synaptophysin, NF, NUN somewhat. And just very quickly, we like rosettes in neuropathology. So we have different types of rosettes. We have the Homer-Wright rosettes. Those are the ones you see in medulloblastomas. You basically have cells and these sort of like neuropil bundles in the center without a lumen. But if you actually see a lumen, another rosette comes to mind, and that's the Flexner-Wintersteiner rosette, and that's seen in retinoblastomas, which I didn't talk about. We don't see many of them. I guess optic pathology sees more, but they are also like basically like peanut-like, a small blue cell tumor-like histology, but they'll have these types of rosettes, more with a like clear lumen type structure. And then I also already talked about these other rosettes, but just to remind you, we also talked about neurocytic rosettes, which also have kind of cells loosely arranged irregularly around some neuropil. Then we have our perivascular pseudorosettes with cells arranged around blood vessels, and true ependymal rosettes, where the ependymoma is really recapitulating a true ependymal lining with a lumen. Those are very rarely seen. Okay, maybe end here because we're running out of time, but in addition to things arising from the brain parenchyma, rarely you can see primary CNS lymphomas. Majority of them are diffuse large B-cell lymphomas, and we sort of subcategorize them into germinal center and non-germinal center, but I think a lot of molecular alterations are now emerging, and probably just the way our hempath colleagues are becoming more molecularly based and restructuring their diagnosis, we're going to be following that type of restructuring as well from primary CNS lymphoma. So I think I'm going to save the talk on GBM for some other time because we're running out of time, but yeah. So I'll stop here, and do you guys have any questions at this point?
I have a question.
Yeah.
We have in these cortical glial tumors, we have 6 layers of the brain, and we have white matter as well.
Mm-hmm.
Is there any difference between these layers and the white matter in terms of presence of this, or kind of starting the tumor or not?
Okay, so you're talking about these cortical-based tumors, like the ones that are associated with epilepsy,
Yeah.
like PXA or gangliomas, and how they're associated with the 6-layer structure. Yeah. There's not like clear associations, but basically the tumor will disrupt that structure, but in sort of like a nodular way. It's not like it doesn't necessarily arise from one layer or another. But it does arise from, I guess, any of the layers there. But what you'll see is just sort of like an expansion of the tumor around the layering.
Okay.
I don't know if that exactly answers your
Yeah.
question. It's an interesting question.
Thank you.
Yeah, there's not a particular pathway, a pattern of it within the cortex that I've seen. Yeah. Okay, thank you guys.